Welcome to the seminar series of the Istanbul University Oncology Institute Seminars in Preventive Oncology. I am Professor Rejin Kebudi from Istanbul University Oncology Institute, Pediatric Hematologist-Oncologist, and also the General Secretary of the International Society of Pediatric Oncology. And as you know, this seminar series is endorsed by the International Society of Pediatric Oncology, SIOP. We have been doing these seminars since December 2020, and today it is the 31st seminar of these series. Today we have a very important topic and a very distinguished guest. Welcome, Christopher Recklitis. I would first like to introduce him. And our topic today is very important for all of us, pediatric oncologists or medical oncologists or radiation oncologists, how to integrate psychosocial care for survivors, adapting the primary care behavioral health model. And our speaker, Christopher Recklitis, let me introduce him. Welcome, first of all. He is the Director of Research and Support Services for the Perini Family Survivor Center at Dana-Farber and Associate Professor of Pediatrics at Harvard Medical School. He completed his doctoral degree in clinical psychology at Boston University and his master's in public health at the Harvard School of Public Health. Dr. Recklitis' research is focused on understanding the psychological late effects of cancer, the development of effective screening measures for detecting distress, and the best methods for encouraging health protective behaviors in cancer survivors. He is the principal investigator of the Project REACH, a longitudinal study of health outcomes in several hundred locally treated cancer survivors. His work has been supported by grants by the National Cancer Institute, Lance Armstrong Foundation, and the Childhood Brain Tumor Foundation. And Christopher Recklitis is the current co-chair of the SIOP, Psycho-Oncology Network, our International Society of Pediatric Oncology, Psycho-Oncology Network. Welcome, Professor Recklitis. The floor is yours.
Thank you so much, Dr. Kebudi, for that wonderful invitation. It's really a great opportunity for me to join you and all the viewers today. As we were talking about before, this is a topic that I think about a lot. I work in this model. I try to share this model with others, and I'm really interested in learning from other people how the model can be used and how it can be useful to people in other settings, other countries, working with different populations than my own. I'm going to start by starting up my slides.
While you're sharing your slides, let me tell our participants, our dear colleagues, if you have questions and comments, please put it in the chat, and we will have at the end question, answer, and discussion time for comments so that we can discuss all these important subjects together. Yes, Professor Recklitis.
Thank you. So let me just talk very briefly about how I plan to use the time today. I'm going to give a very brief introduction, and then I'm going to spend a few minutes doing a pretty rapid review about psychosocial care for survivors, psychosocial needs for survivors, and how that supports the need for behavioral integrated care. And then I'm going to spend most of the time talking about the primary care behavioral health model, which has been adapted obviously for the primary care setting, and talk about how I think it can be very useful and informative to us and adapting it for survivorship care. I should point out that as I am talking, I'm going to really focus on people in the longish survivorship range. So I'm really talking primarily about survivors at least a year off treatment, but maybe many more years. That's the population I work with primarily. Of course, I'm going to be generalizing across different groups, different ages, different diagnoses. And so the implications of what I'm talking about are going to differ according to different practice settings and different populations. It's not the same in testicular cancer survivors as leukemia survivors exactly, but I think these principles and ideas do apply. So jumping into the late effects, I think everyone is quite aware of many of the late effects of our adults and young adults treated for childhood cancer. One of the areas we're aware of course, is education and employment issues. We know as a population, this group is more likely to need special education services. They're more likely to be unemployed or to be disabled. They're more likely to have lower incomes, financial hardship, and health-related unemployment. This is particularly, of course, true in people who had CNS-directed therapy. And in that group in particular, we know, at least in the United States and in some other countries, they are less likely to complete high school or to go to school after high school than their peers. Similar to the education domain, we also know that they have difficulties with adult attainment of certain social milestones. They're less likely to live independently than their peers. This is particularly true for people who have CNS disease, of course, but also as a population at large, we know they're less likely to be married than their peers, and they're more likely to report social and emotional dissatisfaction with their life. I'll point out that D-score is not a very strong effect, but it is a moderate effect, and it is statistically significant particularly in our large studies. We also know that cancer survivors, adult survivors of childhood cancer, report more psychological symptoms. They're more likely to be in the top 10% of people reporting symptoms like anxiety and depression, more likely to report suicidal ideation and symptoms of post-traumatic stress. And they're more likely to tell us that they have symptoms of impaired quality of life in a number of surveys. I think one thing that we don't talk about enough in the behavioral health range, behavioral health specialty areas, these survivors are much more likely to have what many of us call psychosomatic conditions. When I use that term, I'm referring to syndromes that are strongly affected by the interplay of biological, social, and psychological factors. So these are not mental health issues, but these are conditions that have a big psychological mental health component, things like pain, sexual health problems, insomnia, fatigue, health anxiety. These are things that are affecting a lot of our patients, and they have very complex origins. One of the things that I will point out is I've been talking for the last few minutes of all the problems childhood cancer survivors often have, but what I think we need to keep an eye on is the fact the majority of our survivors are in fact well-adjusted. There is a higher prevalence of symptoms in this population, but the severity is usually moderate. Most of these studies that I've shown you report that people have more symptoms, but not necessarily more psychiatric diagnoses and not more major mental illness commonly than their same age peers. Many of our survivors report that that cancer had little impact on them in the course of their life. And of course, we know both in our clinical work and our research, many childhood cancer survivors report that their illness and the treatment actually had positive consequences for them and their life course. So this is a complex picture, and we need to be mindful of that when we think about behavioral intervention services. I think one way of looking at the prevalence and the severity that's useful to me, it came from this study, which is a few years ago, looking at a report from the Childhood Cancer Survivor Study. So this was actually parent reports of children 12 to 17. And you can see here on the graph that the majority, 70%, are actually well-adjusted. They're reporting symptom levels at or below the mean for their age. At the other end of the spectrum, there is a small group, 5%, reporting very high symptoms across the board. These are the folks that likely have a mental illness, would receive a diagnosis if we were to evaluate them carefully. And then, of course, in the middle is the 25% of people who have elevated symptoms, but are unlikely, based on this research, to be folks who have very severe symptoms or to have actually a diagnosis of a mental illness. So this is much in line with a diagram that Ann Kazak has developed to look at on-treatment patients, where thinking really that our kids and families, there's a small group at the top in the clinical range who may have a diagnosis, a moderate group in the middle of mild distress and impairment, and a large group who have low distress and low impairment. And I'm going to come back to this figure as I talk about actually implementation of some of the recommendations that I'm going to be making. Before we get to that, I do want to talk about risk factors. So there are many risk factors, and again, I'm generalizing across a lot of studies and a lot of outcomes, but we do know that shorter time off treatment and younger age at diagnosis tends to be associated with more psychosocial late effects. That I believe is reflecting both short-term and long-term effects of treatment. We know that female gender is also tends to be related with more reports of psychosocial difficulties after treatment. CNS-directed therapy, as I mentioned. I think I also want to highlight here that chronic conditions across the board, a number of different chronic conditions, cognitive and sensory impairments, disfigurement, pain, overall poor health, these medical late effects are highly associated with our psychosocial late effects. As I say oftentimes to our trainees as we're doing our assessments, it's the late effects, folks. It's not surprising to us that people with medical late effects would have more psychosocial late effects. It shouldn't be. We know anxiety and depression are common in new onset medical conditions. So if a patient, years after treatment is being diagnosed with cardiac problems or fertility problems, we should expect anxiety and depression to accompany that. We also know that medical late effects are going to interfere with normative psychosocial development. Our kids are coming out of treatment at different points in their lives. They're trying to reintegrate with school, with work, with peers, with social and intimate relationships. It's hard to do that if you don't feel well. It's hard to do that if your cognitive functioning is slowed for a variety of reasons. It's hard to do that if you're at the doctor's office all the time or you're worried about your health. So there's a lot of ways in which these medical late effects have psychosocial implications. We also know it may not be the late effects itself, but it's actually the experience of the late effects. Medical involvement, just going to the doctor, can be an unwelcome reminder for our patients of their treatment. It can be anxiety provoking and stressful. Also, a lot of our patients have part of their late effect profiles, they have risk for late effects as well as late effects themselves. So there's a lot of uncertainty for our patients. I often sit with patients when they feel anxious in our clinic and say, yeah, I understand you've come today and everyone said you're great, your cancer has been successfully treated, your health is well, but now let's tell us about 4 or 5 organ systems that could go wrong or might not go wrong in the next few years, and then we'll send you on your way. That kind of uncertainty it is really hard for people to manage in some ways. Also, I think because of the medical late effects, oftentimes people can experience some stigma. They can experience alienation from peers. I'm in my teens or 20s. Why am I taking medications? Why do I have to talk about fertility? I haven't even thought about marriage, or now you're talking to me about my reproductive organs. It can feel very uncomfortable for a lot of our patients. So I'm going to try to quickly summarize the points that I've made so far, and that is that in terms of, and think about the implications for psychosocial care. For someone like me, if we're talking about setting up a care delivery program, what do we need to know? Well, we need to know that our patients are going to have moderate severity and prevalence of needs, higher than normative levels, but not what I used to find in my psychiatric clinic before I started working in oncology. What does that mean? It means as a behavioral health provider, I'm going to need to work to identify the 25 to 35% who need intervention. And I need to screen out the 75% or so that are fine and they don't need to talk to me. I also need to be prepared for mild and moderate symptoms, not as many people having a psychiatric disorder as I might see it in a psychiatric clinic. I also need to be prepared for these highly variable needs, right? A lot of these needs are things that are not, some of these needs are inside what we think of mental health, anxiety, depression, worry, but many of them are outside of it, managing fatigue, managing sexual health concerns, fertility concerns. These are things a lot of us as mental health providers were not trained in initially. It also, because we know that their psychosocial needs are tied to their medical late effects, we're going to want to use those late effects both to understand high risk and identify high risk groups. We're going to need knowledge of the late effects to think about intervention targets. And we're really going to need to be integrated with survivorship care, right? If my patient's psychosocial needs are tied to their medical late effects, I need to know what the medical late effects are. I need to know what the medical providers are doing to address them, what they're telling the patient, so I can be helpful to the patient as well as to those medical providers. And that's really the linchpin here for me, is how to be in the right place to do this work. So I'm going to move on now to talk about the primary care behavioral health model, because that really has been informing my work in my clinic for many years. Going to give sort of a brief overview of the history of the model, and then talk about somewhat specifically, talk about how it works in my clinic and some of the roles and services we provide within this model. So my interest in the primary care behavioral health model really solidified about a few years ago. I had an opportunity to work with my colleague Karen Sorelli on doing a review study of how psychosocial services are being integrated for survivors post-treatment in the United States. And part of what we did is, look at sort of best practices. And we had we have this long list you can see on the slide of steps that clinics and programs were taking, the goal of the step. And many of these things are very important. And I continue to believe they're important in terms of, including psychosocial needs in the care plan, establishing provider-patient communication, having multidisciplinary meetings that have the medical and the psychosocial providers together. A lot of these steps are very important. And in some ways, were really the focus of this paper that Karen and I wrote together. But during that time, we also looked somewhat at the different integrated care models which were being put together. And there are many of them. You can see some of them here on the slide. There are some that weren't included. But at that time, I really became very interested in this primary care behavioral health model. And just to read the top of this description, in the primary care behavioral health model, behavioral health providers are placed into the primary care setting to work collaboratively with primary care team to provide integrated mental health care. The role of the behavioral health provider includes providing assessment, consultation, and brief focused mental health care in the primary care setting, as well as referral to mental health setting care when needed. That's actually a description. I'm going to sort of unpack that description and tell you how it works in my clinic. But honestly, there's not much I'm going to add to this except more specifics and more examples. So just as a little background, people are probably familiar that in the United States, and I think in other places as well, we have very limited mental health care resources for primary care providers and patients in primary care. Unfortunately, we have a very high need. About 30% of primary care visits involve a mental health problem. This can be quite overwhelming to primary care providers. At the same time, we have very limited access to specialty mental health care. So 80% of people in the United States who have a mental illness receive no mental health specialty care ever. A lot of this has to do with our limited workforce, has something to do with stigma, has something to do with payment limitations. All of those things are very true. But one of the big problems we also have in our system is even when we have care available, the mental health services are very fragmented. They're located in different facilities. I have many patients who can come to Dana-Farber for their cancer care, but they can't see us for their mental health care because their insurance means they have to go to a different hospital, sometimes across town or in a different town. We're regulated and credentialed and reimbursed differently than the mental health providers, which has a lot of implications for what patients we can see and when and where. Behavioral health providers tend to have a very narrow focus. We, as a group, tend to have limited attention to physical health in many settings, and there's very little communication and coordination with other providers. And that's really what this aspect of the problem is what primary care behavioral health was developed for, to really bridge this gap between physical health care and mental health care. So I'm borrowing this from an example or description of primary care behavioral health model that's been used in our Veterans Administration healthcare system in the United States, which has actually been a real promoter of integrated care. They, as sort of repeat some of what we talked about before, this model basically is putting behavioral health providers embedded into primary care to work side by side with them and provide integrated care. So the roles here are not to, replace specialty mental health care, but to really do part of the work that can get done in primary care. A lot of it is prevention and early identification focused, quick resolution of problems. And as I said, not replacing mental health care, but being an alternative, giving people care who don't need specialty mental health care, or being a bridge, helping them get across that fragmented care system and bridging them so they get the specialty mental health that they need. The other thing which I find interesting is very much how we work is we're always the right door in our clinic. We try to address a wide range of issues like primary care providers do. And whether it's school or work or worried about taking their medication or not understanding their medication or anxiety or depression or eating disorder, we don't ever say to someone, oh, no, that's someone else's problem. Go, call that number. We try to work very closely with our providers and our patients to always be the place to start. We may not have all the information for every problem, but we're always an entry point to try to get the patient the information that they need. So again, working with this VA model, they have outlined certain strategies, and I'll go over them quickly because on the next slide, I'm going to show you how I think they can be tailored and customized for survivorship settings. So in the primary care behavioral health model, one of the goals for the behavioral health person is to support the primary care provider in identifying and treating behavioral problems. We try to resolve problems in the primary care context, do engage in some temporary co-management of a small number of patients, giving them focal services in primary care. We also refer to specialized behavioral care as needed. And in the primary care behavioral model, they really see the primary care provider as the chief customer and the manager of care. I think you can see that translates very quickly or easily to the oncology setting. We are going to support the oncology provider in identifying and treating behavioral problems. We're going to try to resolve some problems in the survivorship context. But again, we're going to refer many people to the community that may be specialized behavioral care, or in fact, it may be back to primary care as needed. We are going to do some temporary co-management of survivors, working with the oncology providers closely, and I'll talk about that. And I would say in my approach, I really see that I have two customers. I have the oncology provider and I have the patient. I have two people whom I'm trying to work to serve their needs and interests. I want to talk about how the primary care role description is really different than what we're used to in many medical settings, including oncology settings. So here, the primary care provider is the team leader. They oversee the medical care and the behavioral health care. In this model, they are the frontline behavioral health provider. So it's not like many medical settings where the physician or the nurse practitioner talks about all the, medical things and then say, oh, the psychosocial stuff, you have to talk to someone else about that. They are the frontline provider and they refer to behavioral health for follow-up care, just as they would to other specialists. One of the things that's different for the behavioral health provider is we, in this model, work as a consultant. It's not our patient, it's the primary care, or in my case, it's the oncologist patient. They can call me in or not, it's up to them. I need to work to be easily accessible. I'm going to provide scheduled and unscheduled visits. So I may have someone on my schedule to see a certain day, but I may get 2 or 3 patients who need contact of some kind that day as well, that I don't know that when I go to work in the morning, but it develops over time. As I mentioned, a lot of this work is going to be assessment, education, treatment. It's going to be problem focused. It's going to have brief interventions and resources and referral. And I'll talk about that in more detail in a moment. So if we're going to support if we behavioral health providers are going to support the oncology provider in identifying and treating problems, what are we going to do exactly? Well, we're going to pay attention to case identification. We have to find that 25%, 30% who need something and separate them from the 75% or so who don't. We need to do some consultation and education with our providers and our patients and our parents. We're going to provide some evaluation and brief treatment, some case management and referral. Let's start off with identification. So again, the oncology providers are going to be the frontline assessors of behavioral health needs. They're going to do that in a few different ways. We, as behavioral health providers, can assist them. We can assist them by selecting targets, by saying, in our clinic, with our population, should we be looking at depression? Should we be looking at substance abuse? We can't prioritize everything. If you're working in an adult clinic with head and neck patients, you probably need to do tobacco control and substance abuse more than I might need to do those things in my clinic. So that I can help my providers figure out what we should be focusing assessment on. And then I can work with them on trying to make sure that the methods that we're using are optimal. That may be the oncology interview, some health history and checklist forms, and also how to make sure that we are giving within our clinic sort of universal access and offer of services. So, I've been working with some of the same oncology providers for almost 30 years. So we kind of know, I know what they do, they know what I do. But with new providers in particular, we talk about, what questions could you ask? We have lists of questions. We've published some on this area as well. These are some of the easy questions. What about your mood? Everyone has bad days, but is your mood down or depressed for more than a day or two? These are kind of the intro questions. We also have more specialized questions around sexual health, around substance abuse. We actually have a team who's coming in, I think next month, they are substance abuse specialists who work with young adults and teenagers. They're going to help us get better at this and continue to learn to do this better with our population. We also talk with our providers about what screening, what checklist measures or what health history measures are being used in our clinic. So this is a kind of review of systems. Patients are often asked to do, throat problems, neurological problems. Oh, I'm sorry.
No, it's okay.
Okay.
Okay. I think, yeah, it was a technical, sorry.
Okay, no problem.
Yeah.
So, we work with them about identifying what behavioral health symptoms they wanted on their review of systems form. And they review these problems just as they do gastrointestinal problems or skin problems as part of their evaluation. These are brief to complete. They fit in the medical setting. Patients doing the checklist anyway, kind of prioritizes the patient's perspective, minimizes the stigma, helps integrate it into the flow of the medical care. It's just one more system people are being asked about. So this has been very helpful for us. We also have done a lot of work with symptom checklist measures. It's part of a research interest of mine. So I've done work on sort of validating and figuring out implementing them in different ways. I would say these screening forms can be very helpful for evaluation, but they're not really, we don't use them as a standalone evaluation. We don't use them to say, oh, you got a 4 on the depression screening, we're sending you to psychiatry because you're depressed. We use them to start a conversation with people about their symptoms. Sometimes they're not depressed. Sometimes they broke up with their boyfriend last week and they're feeling depressed about that. And that's a very different kind of depression. And so we use these, but we use them in a very careful way. We also do a lot of work of inviting our patients and families in. We have worked over the years. It's interesting to find out that we've had services for years and patients don't know we have them. We have learned we need to do a better job, that our services are described in all the patient-facing materials on the website, in the clinic brochure, in the welcome letter. It's mentioned we have a psychosocial team who can help you with these kinds of concerns. If you're interested, let us know. Patients and providers, when they book survivorship visits in our clinic, they're asked, do they need a cardiac workup? Do they need a blood draw? What are they need when they come? Do they need to see the psychosocial provider for a consultation? So that both patients and providers know that we're there and they have a time to book that if needed. We're also present at the medical staff meetings and the rounds and conferences when patients are discussed. Sometimes we hear patients and we say, can I interrupt for 1 second? Hearing what you're saying, I wonder if that patient would be helped by this kind of education or this kind of counseling. So we can make an invitation in that context to our medical colleagues as well. So assuming that someone says yes to all these invitations, we are going to respond to them in some way. Sometimes that response is just referral to an external resource. I get emails from medical colleagues saying, my patient needs tobacco cessation help, and they're, 200 miles away. Where can I send them? My patient, my mother, mother of this patient is concerned about the ADD medication that their patient is taking for his attention deficit disorder. Is there a good reference that this mother could learn more about that? So some of it is just referring them to materials, and I'll give you some examples of that. Some of it is a brief consultation with the provider or patient to find out what they need. Sometimes it's an assessment. It's a half-hour, 45-minute assessment of the survivor. There, the focus is really on triage, and I will give you some examples of that. In all of these response to requests, I try to be one-stop shopping. I know the medical providers are very busy. They need to feel like I am on it, right? That I'm taking this referral from them and I'm going to manage it, I'm going to do something, and then I'm going to let them know what I've done or what I want to do. And similarly for the survivors, they need to know that there's a responsive point of contact. I have help from our administrative team, secretaries, schedulers. I don't do all the patient-facing contact, but they kind of know I'm either directly available or in the background helping manage their concern. So in terms of education resources, sometimes that's giving people information about mental health treatment. Sometimes it's sending people to advocacy and support groups for cancer survivors. I have a whole library of education materials on specific problems: fertility, sexual health, anxiety, panic, depression, fatigue, eating disorder. I've got something. I may send them to internal support or education programs at the Dana-Farber, at our cancer center, or I might send them to community groups. And as I mentioned, I try to have something on a broad range of topics because that's those are the needs that our patients present with. So these are examples of actually education support programs that are happening at our center. We have groups to talk about young adult survivors about dating and social relations after cancer. There's a group for people who have executive function problems. Myself and Eric John, my colleague, do a lot of both research and support services around insomnia. We have groups about how you find if you need a therapist, how do you find a therapist, given all the challenges I mentioned to you in the mental health care system. We also have more teaching sheets about specific problems, as I mentioned. So patient, I'm talking to someone about their depression or their social anxiety. I have professional materials that I didn't write that explain what these are. Or I'm suggesting someone get cognitive behavioral therapy. Well, what is cognitive behavioral therapy? I can explain it to them in a few minutes, but if I send them home a teaching sheet, they can look at it later. They can show it to their family or friends or their providers. And it has a bit more lasting power. So let's assume that this is a case, those are people who need information and consultation. Let's say it's a case where someone I really think needs some kind of assessment from me to figure out what's going on. I'll talk for the next couple of minutes about what that looks like. So in the assessment that I would do with a survivorship patient, I'm of course evaluating their symptoms. I'm trying to particularly understand the duration and the severity and the level of impairment. Sometimes patients have panic attacks and they're working and they're taking care of their families and they're going grocery shopping. And sometimes they can't leave their house. And I need to know pretty quickly where the patient is on that continuum. I need to know if they're having critical symptoms. Are they having suicidal ideation? Are they having, difficulty? They're not taking their medications, which may have important implications for them. I need to know their context. I need to know what supports they may have in their life, friends, family, etc. I need to know their survivor preferences. What are they looking for? Are they looking for therapy? Are they interested in the mental health system? Are they afraid of the mental health system? Have they had those experiences in order to help them navigate? And I need to work really closely with my medical colleagues to evaluate all those symptoms in the context of their physical health. Is this a patient who has cardiac late effects? Are they getting medications for their cardiac late effects? Have those medications recently been changed at the same time that they tell me they're feeling depressed and fatigued? Has their beta blocker prescription been increased? Or are they having neurological symptoms? And that's where the integration, I think, is critical. I need to understand these things and work closely with my medical providers, my medical colleagues, in order to make an evaluation that makes sense. In terms of what I do after I do the assessment, I really rely on those three kind of levels that I showed before. I'm going to start with the low distress group, the blue group at the bottom of our triangle. People who have very limited or no impairment. So here I tend to provide a lot of routine support and preventive care. do some reassurance, anticipatory guidance. You may not, you're concerned about your, I don't know, your weight. It's not a significant problem now, but let's think about, how do people maintain weight? How people do start behavioral health plans around their weight, often providing education, information, resources, as I've shown on the previous slides. I may also be talking with them about the goals and the barrier. So I may be saying, well, gee, you're worried about your sleep. You know what you have to do. You have a plan, but it's hard to do it. How are you going to get yourself to do, to reach the goals that you want to reach? How are you going to manage yourself and manage your symptoms in a way that's going to be successful for you? I may also offer them some ongoing monitoring. I may say, things are going well now, but let's say, 6 months from now, I may say, well, gee, July 4th, that's a big holiday in the US. Around July 4th, why don't you think about how things are going? You give me a call if you need to talk about this more. Or I may ask if they'd like our facilitator to call them or send them just an automated email to remind them that we are available. In some cases, I wrote at the bottom here, the assessment is the intervention. Sometimes a single session with me or one of our social workers talking about this is reassuring for people. They feel better and they can kind of go on and not need a lot more at this time or ever. So my slides are not moving ahead. Okay. Okay. Okay, so as I said, in that consultation, a lot of that work is sort of normalizing their feelings, normalizing their health challenges. I sometimes show this cartoon to our young adults. I don't know if you can see it, but there's a whole street full of people, and they're all having the same thought, which is all these people really seem to have it together, and I still have no idea what's going on. And I think this applies to many of us, or can apply to us at times, particularly for our young adults, particularly because they've had experience. They don't know anyone else who's had these experiences. They think everyone else is doing great, and they're the only one who have these issues. So a lot of it is putting it in a developmental context. I'm going to skip for a moment to the high intervention or high distress part of our triangle there. These are the people who have the most symptoms. They're in the clinical range. They likely have a psychiatric diagnosis. And here, my approach is going to be very different. I'm going to be trying to figure out what is their likely diagnosis. What are their treatment experiences in the past? Do they have a care team now, or did they have one? Do they have urgent or emergent needs? Do they need to go to the hospital? Do they need to have family members intervene because they're not functioning? Really, my work here is try to refer them to specialty mental health care, figure out where they should be going. I may be monitoring that, making sure that they get there. How can I be that bridge? I may, how are they going to access behavioral health services and supporting them around that? I may also be offering some backup and bridge services. Oftentimes patients, I had a young man who had been sober from alcohol abuse for several years. He relapsed. He was deeply ashamed. He was very upset with himself. We were able to get him back into care, but he had to wait for 3 weeks. And so our problem, he and I together, is what are we going to do with you for 3 weeks? How are we going to help you? And so part of that was visits with me. Part of it was visits with other folks. Part of it was referral to self-help groups so that he could be managed and maintained during that 3-week period. So as I said, in that case, I'm really using my mental health expertise to support that bridge to specialty mental health care. I'm going to try to guide the mental health treatment, help the patient get ready for it. As they get ready, as they're being interviewed, think about their insurance. And the sort of intensity of my work with that patient is going to depend on their needs and what their resources are. If they have an involved family who can do a lot of this work, that's going to make it very different than if they don't have any social support as they're getting ready for this service. And of course, the urgency is going to matter as well. I can tell you I had an oncology provider forward me some concerning emails from one of her patients. It was a young man who was emailing her saying, I'm not sleeping very well. I feel like, my thoughts are kind of scattered, and then sending another email saying like, I'm not sure if, some of my thoughts are really real or not. And, she said to me, oh, I'd really like you to see this patient. He's struggling. And I looked at the emails and I said, no, I'm not seeing that patient. I think that patient may be having a first psychotic break or a bipolar episode, and he needs to go to urgent mental health services to get that taken care of. And unfortunately for him, that was the case. Fortunately, he's doing well. But that's a sort of high immediate need case, but that's a very small minority of the cases that come to me. So I saved the hardest cases for last. These are the mild distress, moderate impairment. These are the people that I see all the time. They're potentially the most complex because it's not clear what they need. I need often to do evaluation for them. I may do sort of routine care, monitoring, education, reassurance, anticipatory guidance, send them to self-help resources as needed. But I also need to figure out, is that enough for these people? Do they need more? Are their symptoms interfering? What does the patient want? What are they looking for? How do they think they're going? What does the provider want? So oftentimes that's not the same. So I need to negotiate that. The oncologist saying, this patient is having panic attacks. You need to do something. And the patient saying to me, yeah, it's all right. I just, I have a panic attack. They feel terrible. And then they go away and I'm not really interested in doing anything. I need to really work with them and often figure out with them a range of different options. I try to make sure that my offers are not time limited. I think a lot of times in mental health care, a lot of medical care, we ask people today, okay, well, you could have medication, treatment, or you could have, ECT. What do you want? And patients often feel like they have to decide today. And I try to say to patients, you know what? I'm going to put out a menu, and you're gonna decide what you want today, and you may come back a year from now or many years from now and want something different, and that's fine. With these patients, I often do some follow-up monitoring or make sure they know they have follow-up with us. The panic disorder patient that I saw who really just tolerated her panic attacks in a way that most of us, I don't think, could. I just let her know what might change, and I told her what treatments were available and that she could come back and let me know when she was ready, which it turned out she did many years later. Sometimes what I will do with those medium range patients is do some short-term brief treatment in my survivorship setting. This is always a small number of meetings. Sometimes they're brief encounters. They may be 20 minutes, not, a whole 50-minute hour. It's focused on a focal problem that we agree upon. And we often address whether the barriers to care they're experiencing. Sometimes these take the form of an extended consultation. Someone I feel like they need more than one visit, but maybe 2 or 3 visits and they'd be done. Sometimes it's co-management of a medical challenge. Patients coming back, maybe they're being, diagnosed with some heart problems or fertility problems. There's anxiety and uncertainty. They're coming back to the medical center to see medical providers. I will try to sort of co-manage the behavioral health part of that as they're working with our medical providers to figure out the medical piece. And sometimes, as I mentioned, this is sort of a bridge to specialty care while they're waiting or trying to get to mental health specialty services. I'm kind of filling in. I do need to resist the call to provide all care for all survivors. Many times, as my medical director says to us, people think that I'm the solution, and I'm not the solution. Like my patient who is having, a first psychotic break, I am not the best person to manage that in the cancer survivorship setting. And sometimes I need to educate people and say, that's not what I do. You will be better off with someone in a different setting. It's important, I think, for us to realize and talk about this model. The cancer center can provide optimal care in some circumstances. We have access to the survivor. They trust us. It's convenient. We understand their treatment and their medical late effects. And if we're using this model, we're integrated with the medical care. But sometimes we don't provide the best care. In oncology settings, patients may have very complex medical needs, and it may not have time and space for some of these behavioral health needs. we may not have behavioral health expertise patients need. I think I'm a reasonable psychologist and I have good training and experience, but I'm not an eating disorder specialist. I'm not a specialist on, behavioral outbursts of people who have central nervous system, diseases or post-stroke patients. I can't be everything to everyone. None of us can. Also, distance and availability are barriers. Where I work, I'm in a regional center. People come from hundreds of miles away for their cancer treatment, but it doesn't make sense for them to come hundreds of miles for their behavioral health treatment. And sometimes it maintains a psychological dependence on the cancer center that's really not helpful for kids or families. So because of that, I do try to resolve problems in the community. As I mentioned, I try and connect survivors to community resources, including primary care, work with them to understand the barriers to care. And I try to really do this in a psychosocial way of promoting development or integration with the community. A lot of these patients spend a lot of time with doctors and cancer specialists as they've grown up, and it's hard for them to connect with peers and work in school settings for a variety of reasons. So I really try to promote that because it's going to be helpful for them in their whole psychosocial development. We have a lot of materials that help promote referrals. We have this education sheet that explains why you might want mental health services, how to access and how to find them, what are different kinds of mental health providers, what kinds of therapies are available to our patients who need specialty mental health. I do a lot of emailing to patients after visits, follow up, it was good to see you. This is what I suggested. Here are the resources that I sent with you. I always sent this to the providers because I've learned patients come back and say, oh, I saw Dr. Recklitis. He didn't do anything. He didn't help me at all. And so it's helpful to have the email for everyone. We don't have to start over again. I think it's important to realize some of our survivors may have limited access or limited interest, I should say, or motivation in treatment. They have their own goals. They have different experiences. Many times they're young. They don't have experience with treatment. There are costs, there's stigma. Also, many of them have low intensity symptoms. They're busy. They're playing soccer and they're working and they're going to school and they're trying to get back to their pre-illness roles. And so this may not be a priority. I really try to respect that. I try to educate them. I am very honest in my communication. I say, it seems like there are people in your life who really think you have a problem. Your parents, your oncologists, your whoever it is. I say, my job is not to make decisions for you. My job is to give you all the information so you are happy with the decisions that you make. And I really try to focus on their goals and not get into power struggles. Partly, I think it's good practice. Partly, as I tell my patients, I'm a very stubborn person. I don't like people telling me what to do. So I'm not going to try to do that in my work with you. I also say to patients, I know many of my patients have a wish to forget about their cancer. And they don't want to think about it all the time. But sometimes they also find there's times they need to acknowledge it or integrate it or cope with it. And you need to figure out if this is one of those times for you or not. That can't be up to me. I will point out that I'm a big fan of the primary care behavioral health model, but as I get ready to finish up, I'll say there are challenges. Change is hard. This model requires changes in psychosocial roles for medical and psychosocial providers. There are medical providers who love to talk to their patients about their anxiety and depression, and there are medical providers who don't, and there are psychosocial providers who don't like this model, don't like being pushed out of being in charge of the case into being a consultant. There are care delivery system issues and workforce challenges. It's also important for all of us to remember that some behavioral problems don't change easily. We do what we can. We do more than might have been done without this model, but we have patients who continue to have problems chronically. And I think finally, it's hard to demonstrate sometimes to our administrators and our payers that this approach has value, although in the primary care behavioral setting, outside of cancer survivorship, there's a lot of research showing that this is very economically helpful and very helpful to medical providers who have more time to do what they really want to focus on. So in closing, I will say that, I think one of the advantages here is that this model can be tailored differently to different populations, to different oncology providers. It can utilize the strengths and resources that are available in your setting, not necessarily in my setting. I think it's really an approach and a way of thinking about integration that's important and valuable. One of my thoughts, and I work with colleagues here in America who don't work in specialty cancer centers, and we talk about, well, what if you don't have a mental health specialist at all? What can you do? And we talk about, teaching sheets on common issues, having education programs either done in the cancer survivorship setting or referring them out, by mail, by phone, by the internet, getting connected with medical, social advocacy, faith-based groups in the community. What is available to your patients in the community and how to make that less fragmented, how to build a bridge from survivorship to things that are already existing. I think having these materials and having ways to help people access them can reduce the burden and also the stigma for both patients and providers. If there's a teaching sheet about panic disorder, or about anxiety in the waiting room, patients know it's okay to talk about it, and providers can just say, oh yeah, grab that teaching sheet on the way out, rather than thinking, oh my gosh, what am I going to do about my patient who has this issue? If you have more resources than that, if you have some non-mental health specialists, but you maybe have a volunteer, you have a nurse, you have a bachelor's level social worker, many services can be added. There can be, parent, patient, paraprofessional-led support groups. There can be care navigation. Some of the things I say I do in my practice, calling people back, seeing how they're doing. Did you get to that, program that we sent to you? Did you find the information? I think that can be very helpful. There can also be work by paraprofessionals, non-mental health professionals on informing patients about resources, doing a survey of what your patient's needs are, and doing more support care coordination with the community. Oftentimes we have this problem. We have many, many things in Boston. We have all kinds of clinics and survivors that programs and specialists we don't know, and they don't know us. And we find if we invite them into a meeting, if we invite them in for coffee, if we invite them in, suddenly we know them, they know us, and the bridges get built pretty quickly. And of course, if there is a mental health specialist available in your setting, they can do a lot of the things that I was explaining today, or they may be different things that are appropriate to the patient needs in that setting. I guess I will say finally that there are a lot of opportunities in this area. The last 50 years, survival rates for pediatric cancers, as everyone on this call knows, have increased dramatically. And with all those survivors, obviously we have more late effects, but we've done a lot of work to understand and have an evidence base for psychosocial late effects. We've done a lot of work trying to implement them and develop care guidelines. We really have the tools to do a lot now, I think, to put these, to address these needs in our survivorship settings, to identify interventions to address them. It's a lot of work, but it's a really exciting time to be doing this work. And that's where I'll stop.
Well, thank you so much. This was really an excellent lecture to all of us, and it is a very important topic. We have 205 participants at the moment from 19 different countries. Thank you to all participants for being with us. This also shows how important this topic is. So we, as pediatric oncologists, we believe in multidisciplinary approach, and really the psycho-oncology, the psychosocial support is so important when we are treating and also when these patients survive. And as you have mentioned, health is very important. We have to, when we define health, it's both physical and mental health. So we have to have the mental health also. Now we have some comments and some questions which I would like to direct to you. And our Mrs. Hazal, she is a nurse. She has 1 minute. Please. Yeah. So what can we do as an oncology nurses to improve psychosocial interventions for survivors? I'd like to add to that question another question also. Thank you, Hazal, for asking it. Because even in high-income countries, as you have said, some patients do not have access, like 80% will not have access to a mental health provider. But especially in low middle income countries, this can be even more pronounced. And in many centers that we will not be able to have a psychologist with us in the same center or in other centers. The ones that we have, we are really lucky to have them in our integrated setting, but otherwise it is always a problem. So what can we as medical doctors or nurses do in the oncology setting? And in addition to that, Dr. Ülkü Miray Yıldırım, she is a pediatric hematologist, oncologist, and she is the co-chair of our SIOP palliative care working group, newly elected. Congratulations, Miray. She's also she says, because in fact, some of our secretaries working in our clinics for a long time are just the frontline behavioral health providers, because they know the patient for a long time. They have been coming there for maybe 10 years. So when they see a problem, they tell us, the medical oncologist or the nurse, of the problem. So in these kind of settings, what do you propose when we don't have a really experienced psychologist in these settings in low middle income countries, how to approach these problems as our team, the nurses, the oncologists, or sometimes our experienced secretaries?
Yeah. I would start by saying thank God for the administrative staff and for the secretaries and for the nurses, because they spend often much more time, more consistent time and different time than medical specialists or behavioral health specialists. They are more relaxed often with these folks. They talk a little bit more, maybe let their guard down in a certain way. And so I think it is very fortunate for the patients and for us that these folks are doing what they're doing. I think that, there's sort of a couple of pieces here. I think that one thing that we can do is try to support those folks in doing what they're doing. So I think even talking about the fact that the schedulers in our clinic, the secretaries, are doing this work, or they're fielding these issues, it needs to come out into the open. Sometimes it's a little bit of it's an open secret, we say in English. It's sort of, we know it, but we don't talk about it. And saying to them, well, what is that like for you? How can we help you? I say to them, for instance, I'm just working on now, I have a whole list of urgent, support lines when patients don't need to, it's not an emergency, but they want to talk to someone. We have support lines for, relationship problems, for substance abuse, for young adults. And I said to our secretaries, our schedulers, like, well, I have a whole list of these. Would you like that list? So when patients mention it to you, would you feel comfortable asking them if they want this information instead of sending them to me? And they usually, some of them say, I don't want to see the psychologist. And so some of it is kind of sharing what we might do with folks who are on the front line. So I think sharing the resources, sharing the tips, some of it is giving it to them directly, saying, well, you could offer this stuff, or you could let them know it exists and ask them if they want something. I think there's certain things you don't want to overburden the frontline staff. You want to turn them into the social workers, but you want to acknowledge what they're doing. So I think part of it is saying to them, well, let me tell you, here's a list of things you might want to offer. Let me tell you what I offer, and you can mention it to the patient. You say, oh, you're lonely, you're at school. Did you know that, the Dr. Recklitis group, they do once a month, they do a Zoom, check a group for young adult survivors. You could get on and talk with other survivors. Maybe you would like that. Because I might be doing that, but that particular secretary or nurse doesn't know I'm doing it. So some of it is building the communication in a way within our team that's open, that helps the frontline people do their work, but doesn't burden them and say, oh, in addition to your job you're doing, you have to do more things. So, and again, I think that's going to be different settings and with different providers. I think that's a piece of what you're bringing up. I think the other piece of is what do you do when you have very limited resources in terms of access to professionals or access to specialty treatment? I think a lot of what you do is education. I think a lot of what you do is finding those materials that are going to be in address the right need, in the right language, at the right reading level. And that takes a while. That's not, you don't do that in a day. because you find materials and you see what works, but then to be able to share that with someone and say, you know, I understand, like you're having panic attacks. I know you think you're going crazy and you're losing your mind, but I'm not sure that's really it. Let me show you this, you know, 2-minute video that explains what panic attacks are. Let me give you a teaching sheet. Let me tell you a little bit more about what this is, that you're not going crazy. But it feels terrible when you have these. And there's some things you can do on your own. You know, you can do some self-management. There are some treatments. We may have trouble finding them for you, but I'll tell you what they are. And then we'll figure out what's possible for you, whether it's medication, whether it's behavioral treatment. But I think the stigma and the sense of fear can really be addressed through compassion, through education, through support, which I think nurses are probably the best professional to do education, compassion, and support. And so I think as I said before, to try to take the resources, you know, that I might have or you might have, or to pull them together and make them and share them and get them to people. I think it's not going to cure someone's panic disorder. It's not, but it's going to make it much more livable for them.
So education on psycho-oncology, both for us, the medical doctors and the nurses, is very important. It is good to have our psychologists and psychiatrists who are really experiencing that. But when we don't have that resources in some centers, in some countries, the nurses and the medical oncologists and the other medical staff that are at least educated in some of these primary problems will help at least to identify which have really to see the psychiatrist, because there's limited time and limited resources. So I would like to...
I would just say, I think the other piece of that is for the staff to have, you know, even if it's an hour a month with the mental health professional to talk about cases, to not feel like they're having to do it alone could be really helpful.
Yeah. So that and it's something that you have said, it is so important that you inform the medical staff of what you have talked with the patient, so that afterwards they can say, we talked and there was nothing that we talked about. So everyone knows what is being talked and how they can help her. This is very important. I would Dr. Nurdan Taçyıldız, the president of the Turkish Pediatric Oncology Group, is thanking for your very excellent lecture. And in fact, Dr. Nurdan Taçyıldız, the Turkish Pediatric Oncology Group, has a survivorship program, which Dr. Nurdan and the team and many of us have supported her in this program. And thanks for having the program. And it is really very important for psycho-oncology, psychosocial support, and also for the other supports, because survivorship is really a very important topic. Thanks, Dr. Nurdan, for that. And Dr. Dilek Anuk, Associate Professor of Psychology, she is in the Istanbul University Oncology Institute, Department of Preventive Oncology. She is in the Psycho-Oncology division. Dilek has been working with survivors for a long time. And she says, first, she thanks for the presentation. And also, as a psychologist working in the field of psycho-oncology in Turkey, in the Istanbul University Oncology Institute, depression and anxiety are generally observed in the initial period of the disease. And according to our observations, recurrence or metastasis can also be psychologically very effective for anxiety and depression. And can you comment on that and the stage of the disease and even if they are cured, if they had an advanced stage, always they having fear of a recurrence, how does that affect the survivors?
Yes. So thank you for that question. I think it's a very interesting one. I will say this is actually an area where we have done some research with our local cohort, both around second cancers, which may come, of course, in our childhood cancer survivors coming decades later, often after treatment, as well as recurrences. So it's been interesting to be able to do some of that research, and I can speak to that, although this is a very complex area, obviously. I think this is an area where the disease, the stage, as you mentioned, the time of recurrence often has very important implications, both obviously for the medical outcome as well as the psychosocial outcome as well. one of the things that we found very interesting is that there are certain patients we are finding that even people who've had a recurrence and they've been successfully treated often have elevated anxiety and depression years and even decades after. You know, we think a lot, oh, the patient is recurred. Of course, everyone is stressed now, the whole team, the family. This is a crisis, and then we think, oh, but the recurrence has been successfully treated. They're doing fine. It's fine, and that anxiety and depression goes away. And it turns out that may not be the case. It turns out that may set them up for more anxiety and depression even after successful treatment. So that's definitely one thing we've observed, although I'd have to say the data suggests that's clearly the case for our brain tumor survivors, for people who have CNS disease. It's less clear if that's people who have non-CNS disease. I suspect it may be for some, and we're still learning about that. Again, I think part of this is, and I think there's different pieces, right? So some people are afraid because they have to get more treatment. Some people are afraid because they think they're going to die. Some people are afraid, because they can't go back to college. I have patients who have, completed their therapy during high school and they transition to college and then they have to go back home. They're more worried about being at home with their parents than they are of anything else. So I think it's very different for different patients and presentations. I would say I think the thing that I've become aware of in the last few years is anxiety and depression do happen, as we know, around recurrence and second cancer. I don't think they always resolve even when the cancer does. And that's something we need to think about as clinicians and also as researchers.
So Professor Christopher Recklitis, thank you so much for this excellent lecture. And thank you for all the participants that have actively participated in our program. And I would like to thank the Istanbul University for this series, for giving the opportunity, our rector and the Istanbul University personnel for giving this opportunity to us. I would like to thank SIOP, the International Society of Pediatric Oncology, for endorsing and announcing all these seminars so that many people can have the chance to listen to them. I would like to thank Dr. Club for the technical facilities that they have provided to us free for the pediatric oncology community and the children with cancer, because all this education helps our children with cancer. So I really thank you a lot for this lecture, and we hope that we will meet next month with another seminar. Thank you so much.
Thank you.